The next one I wanted to talk about was the role of combination antiplatelet and anticoagulation therapy in diabetes and cardiovascular disease. These are insights from the COMPASS trial. Could you take us through a little bit of what we saw there and the clinical takeaways from your opinion?
It was really a privilege to present the COMPASS diabetes results here at ACC virtual. It was an exciting meeting, of course, doing it virtually. And what we showed in COMPASS diabetes really was the benefits of low dose rivaroxaban, 2.5 milligrams twice a day, plus low dose aspirin. So that was compared against aspirin plus placebo in the overall COMPASS trial. That was 27,000 patients with PAD and or CAD randomized to the two therapies I mentioned, overall showing a significant reduction in ischemic events, lower all-cause mortality as well. And what we did in this analysis was specifically look at the subgroup of patients with diabetes. And the results in many respects parallel the overall trial with significant reductions in the primary endpoint of cardiovascular death, MI, stroke, also significant reduction in all-cause mortality, and a significant reduction looking at a composite of cardiovascular and peripheral adverse cardiovascular events, an expanded base, you could say, in there, as well as significant reduction in those with diabetes. Now, the overall trial in the non-diabetes subgroups also had similar sorts of relative risk reductions, but where there was a difference in those with diabetes is in terms of the magnitude of absolute risk reduction, where there was, for example, a threefold greater numerical decrease, you could say, in the mortality with rivaroxaban plus aspirin versus aspirin alone in those with diabetes versus without diabetes. So essentially, at least in terms of numerical absolute risk reductions, these were substantially larger in those with diabetes versus without diabetes. Now, that's not to say that the combination doesn't work in those without diabetes. It actually worked quite well for the endpoints I mentioned, very consistent findings, but in terms of absolute risk, those with diabetes really gained a substantial benefit. So I think the take-home message is, first of all, in the COMPASS trial, this regimen, some have called it a vascular protection regimen of rivaroxaban plus aspirin, is effective across the board in the patient population. We studied high ischemic risk CAD and or PAD patients that are at low bleeding risk. But beyond that, now we see in those with diabetes, a particularly high risk subgroup, everybody knows that this is really a substantial advance, and the combination, dual pathway inhibition, combination of low-dose rivaroxaban and aspirin really is quite effective. Now, the only caveat I'd provide is in the diabetes subgroup, as in the non-diabetes subgroup, as in the overall trial, there is a significant increase in major bleeding, though fortunately no significant excess in fatal or intracranial bleeding. So do need to be cautious in terms of patient selection. It's only a strategy to consider in patients that are at low bleeding risk. But if they are at low bleeding risk, high ischemic risk, and they've got CAD or PAD, and they have diabetes, that's a very appealing population in which to use this therapy. Though again, even if they don't have diabetes and have multiple other risk factors, polyvascular disease, stable heart failure, those are some of the other subgroups we've identified in COMPASS that derive great benefit. So bottom line, if they've got high ischemic risk, a prime example of which is having diabetes, and otherwise fit the COMPASS CAD/PAD eligibility criteria, you ought to consider this regimen.